So let's get started.
Great. So we have organized some of the questions that came in into kind of different questions that follow different topics. So we'll start off with some of our basics of cholesterol questions. Some of the questions that came in, where should my numbers be and what kind of numbers can people be expecting with step one when it comes to their cholesterol?
And the best way to raise HDL. Okay, so just basic cholesterol, right? When you get your numbers, you typically get four numbers. One is the total, the other is HDL, third is LDL, and the last one is triglycerides. So the total cholesterol is the total. It kind of incorporates those other three numbers, and the total cholesterol should be under 200. But honestly, total cholesterol gives us limited information because, like I said, it's a total. So it's a combination of good cholesterol, bad cholesterol, triglycerides, and you can have various combinations of those and end up with the same total number, but with different health implications. So in general, especially for someone interested in prevention and preventive cardiology, I'm far more interested in what's below the line. Okay, so HDL. HDL is the good cholesterol. This is cholesterol that is not depositing in your arteries. It's on its way out. So we actually like to see that number high. In men, it should be over 40. In women, it should be over 50. Anything below that is an additional risk marker for a more, higher risk of developing atherosclerosis. Very high levels, were thought to be super protective. So if your HDL was high, don't worry, nothing else matters because you have so much good cholesterol, you don't have to worry about anything. Well, that thinking is really is being set aside because what we're learning is that number one, HDL is not infinitely protective. So it's not like, if you're 100, it's so much better than 80. So like I said, it kind of falls off in terms of its protective nature. The other thing we're learning, and this is maybe more so in men than women, but even in women, very high HDL levels may actually be associated with also a higher risk. And the reason for that is unknown. This is new kind of data, so I wouldn't get too excited about it. But it sort of makes sense, right? If HDL is the elimination form, why is there so much of it in our bloodstream, right? Why is it having trouble leaving, right? And if it's cholesterol, it could still be accumulating in the arteries. But I think we're at the early stages of that. I think the most important thing about HDL to keep in mind is if it's too low, it's a problem. If it's high, it's not infinitely protective. So again, it should be over 40 in men, over 50 in women. LDL is the cholesterol we obsess over because LDL is the cholesterol that could be depositing in our arteries. So we want that number as low as possible. LDL or cholesterol is part of atherosclerotic plaque, the buildup of gunk inside our arteries. In fact, we cannot have plaque without some cholesterol being in there. And the stuff that gets in there is LDL, which is why we're so laser focused on that number. Most cardiologists would say, hey, everybody's LDL should be under 130. As you accumulate risk factors, and that could be a history of smoking, family history of heart disease, a low HDL, boy, we'd really like to see that LDL closer to 100. Once you have documented heart or vascular disease, so you've had a heart attack, stroke, bypass surgery, stent, we'd like to see that LDL under 70. And there's even data to show that under 50 is additionally protective. So the main message around LDL is the lower the better. Okay, triglycerides are not much of a cholesterol particle. These are mostly fat, and so they don't contribute that much to the total cholesterol, which is why you can't just add the three numbers to get the total. Total equals LDL plus HDL plus about a fifth of the triglycerides. Normal triglycerides fall under 150, but they have a very wide range. So very different cholesterol particle, very, very, just behaves differently, lives on a different scale. The lowest triglyceride I've ever seen were, in my own practice is 27. This is someone on no medication, but the highest I've seen is into the thousands. So it's a ginormous range. Everyone's supposed to be clustered under 150, but absolute changes in triglycerides, even though they might look startling, like, oh, this changed by 20 points or even 30 points, right? If you keep the scale in mind, that can be a relatively minor perturbation or change from a previous reading. The thing we're most interested in is the direction in which triglycerides travel over time. So if your triglycerides going up and up and up, that typically says, hey, something's not quite right metabolically with this person. Triglycerides can be the canary in the coal mine for insulin resistance, prediabetes, weight gain, poor diet, lack of exercise. So if anything is going to give you up at a medical visit, it's going to be your triglyceride levels in terms of whether you've been doing your part in terms of lifestyle efforts. But things, they can change even overnight depending upon what you ate the day before. So they live on a bigger scale. They're much more variable, and they contribute relatively little to the cholesterol profile. I mean, to the total cholesterol. They should be under 150. Levels that are very high, over 500, and especially over 1,000, have their own health implications and require treatment for that alone. Okay, what numbers can I expect with step 1 foods? Well, on average, in 30 days in the clinical trial that we did, we saw an average LDL reduction of 9%. So obviously that'll depend upon where you started. So, take 9% of your start. That was our average, but it varies, right? People are very, everyone's unique in terms of how they respond to treatment. You can put a patient on blood pressure lowering medication and nothing happens. And despite, putting them on high doses. So everyone responds differently to interventions, which is why if you're doing this specifically for cholesterol management, we always advise you to check and see what your individual response was. But there are absolutely people who see incredible results, rapid reductions in LDL that really rival what they would see with a medication. So this can be a really, really useful intervention for people who can't use medications, who don't want to use medications, or who are not at goal for their LDL level despite maximum tolerated statin or medication doses. So LDL is reduced. In the clinical trial that we did, we saw slight increases in HDL, so some improvement. It was not statistically significant. And triglycerides, fell a little bit, but it really was not, there was not much of a change. Now that we might have seen bigger, more significant results if we had a larger group of people or we followed people for a longer period of time. What is the best way to raise HDL? HDL can be very difficult to move. Sometimes it is genetically driven, and a low HDL is just a low HDL, and there's nothing you can do to change it. In the vast majority of people, some things can be done. Exercise, becoming physically fit can have a big impact on HDL cholesterol. The types of fats you eat can have a big impact. So unsaturated fats, fats that are liquid at room temperature, olive oil, the oils in nuts and seeds, oils in fish, avocados. All of these oils, these fats help raise HDL cholesterol, so they can be very helpful. And then there's unsaturated fats, so fats that are solid at room temperature come primarily from animal sources, right? The marbling in beef, the fat in chicken, cheese, cream, butter, all the good stuff. That tends to be neutral on HDL, does not seem to do much at all. People with type 2 diabetes, pre-diabetes, insulin resistance also tend to have a low HDL level that often comes along with a high triglyceride level. So losing weight, getting blood sugar under better control can also have a big impact on HDL. There has been data that's published that says drinking, moderate amounts of alcohol can raise HDL. This is not a wise way to raise HDL. Alcohol comes with all sorts of, baggage that may not be ultimately health promoting. Super bummer, but it is something that has been shown to raise it. So, that's another thing that we know can impact HDL.
Great. Before we move on to the next slide, we had a question that came in. How often should our cholesterol be tested?
So if your cholesterol is sort of, it depends, right? So if your cholesterol is normal and we're just, doing preventive screening, routine preventive screening, what I would say is everybody should have a cholesterol check, once before you turn 20, a couple of times. And this is just an easy way to kind of keep a reasonable schedule in mind. So twice in your 20s, 3 times in your 30s, 4 times in your 40s, at least every other year in your 50s, and yearly thereafter. So the frequency goes up because the chance of cholesterol becoming abnormal also goes up as we age and our health changes and we develop other health conditions. If your cholesterol is abnormal and you're started on a therapy, for medications, typically we'll recheck your cholesterol profile in 2 to 3 months. Because Step 1 Foods, was evaluated in a 30-day trial, something between 30 and 60 days is plenty to see whether or not you are someone who can, has a significant response to these foods. To be honest, I actually thought that, it was kind of people would get what they got after, 30 to 60 days. Like if you lowered your LDL by 20 points, like that was it. And I've been proven wrong. People, who have continued on with the foods and have shared their longer term cholesterol profiles have shown us that LDL can continue to reduce. So that's super exciting. But 30 to 60 days for Step 1, 2 to 3 months with medications, and then further follow-up will be dependent upon your response.
Great. I think we hit on this answer a little bit already previously when you were talking about triglycerides, but we had a customer named Donna who said that she has been using the products and she saw a 46-point LDL drop and a 52-point drop in her total cholesterol, but specifically was asking about her triglycerides and HDL, and if there was anything she could do with those numbers. I think you've hit on the response to this pretty clearly, but was there anything else you wanted to add to this?
Yeah, so I think, when you have a significant cholesterol reduction, total cholesterol, if your LDL is down, if your total cholesterol is down 52 points, there's only so much HDL you can make. So sometimes, HDL comes down as well when total cholesterol comes down, but it looks like the HDL went down way less than the LDL. So the ratio and the relative, benefit should still be quite significant. Triglycerides, again, can be quite labile. 20 points might be a nothing, as long as they are still in the normal range, or even just a little bit over. That's not a big concern. So I look at this and and I'm most excited about the LDL going down 46 points. That is a huge reduction in risk.
Great. Well, jump into some questions about Step 1 foods. I think this is a common question that we get. Once my cholesterol is in the normal or healthy range, do I need to continue to eat Step 1 foods?
So, Step 1 foods and frankly, even medications for cholesterol lowering are not like antibiotics, right? Where you do something for a limited period of time and you're cured. This is an ongoing effort. So the reason why Step 1 foods worked is because you filled in some nutrient gaps or you added in nutrients that are especially, powerful in your body to help lower LDL. Same thing with medications. If you take a statin, they have changed the way you handle cholesterol and you make cholesterol in the liver. And all of those things will keep working so long as you continue to do them. When you stop the medication, if you stop step 1 foods, if you haven't done anything else different, your cholesterol will come back to baseline. I love to see people make additional changes. So if you've noticed that you've had a nice response to step 1 foods, okay, keep going and then layer on other interventions that support your efforts, right? If you've been inactive, add exercise. On the food part, continue to increase, an intake of whole, unprocessed, plant-based sources of food. That doesn't mean you can't eat chicken anymore or anything like that. But again, look at the quality, the overall quality of your diet and see where you can make improvements. My greatest, excitement would be if we could take what's in step 1 foods and just do that completely, throughout the day and not need the foods anymore at all. But the truth is it's hard to get some of these nutrients in the right amounts, which is why step 1 foods is such a nice, foundation for dietary improvements. And it's and it can serve, whether it's not twice a day, even once a day, to really help fill some of those nutrient gaps that can be driving cholesterol levels up.
Okay, great. The last question on this slide is something that came up from a couple of different questions. I've lowered my total cholesterol and my LDL with step 1 foods. If my levels are lowered, can it stop the plaque from forming in my arteries?
So in general, 1% LDL reduction is equivalent to 1% reduction in cardiovascular risk. So it's meaningful, right? If you lower your LDL, you are reducing your risk. So that's risk reduction. In terms of plaque, plaque can form for a multitude of reasons, right? Not just cholesterol. There's also blood pressure and smoking and blood sugar. So cholesterol doesn't solve it all. If you look purely at cholesterol, right? If you just look at what levels do you need to halt this process or to regress it, it's actually quite low. Cholesterol on its own, you need to get to LDL levels under 70, which is why that 70 number is the goal for people who already have established atherosclerosis. And for regression, so undoing some of the plaque, it's not complete cure, but to undo it, you need to get to LDL levels under 50. That's why that 50 level was another cutoff that I brought up earlier. But again, this is, you don't necessarily have to completely halt this process or reverse it to avoid heart disease, right? This is a balance between, hey, how much medication do I need? What is my risk, right? If your LDL is reduced, you have reduced your risk, and that's the most important thing.
Okay, great. We had another couple of questions come through. We had questions before and a couple of questions here on the live that are asking questions about lipoprotein A and the impact that step 1 foods might have on that.
So lipoprotein A is a genetically determined risk marker. So it is something that just is. There is no amount of exercise you can do to modify it. There's no amount of broccoli you can eat to impact it, right? It's a purely genetically driven risk marker. And you can think of lipoprotein A as being like an extra protein that floats around the bloodstream, attaches itself to LDL, and makes it more toxic. So that for any LDL level, it's actually worse. Lipoprotein A is present in elevations of lipoprotein A can be found about 20% of the population. So it's actually amazing that, this isn't being routinely tested. But if you haven't had this done, you may want to ask to have it done. It's a blood test. It can be done at the exact same time as your general physical. And there's no urgency, right? You don't have to run to the emergency room to have your lipoprotein A checked. This is a genetic, it's a genetic marker of risk. And I just want to be clear, we're talking about risk factors. We're not talking about disease guarantees, right? And I sometimes see people who have an abnormal lab test and they completely freak out. And we all want normal labs, right? That's the easiest thing. But just please know, these are risk factors, and everyone responds to their risk profile uniquely. It's the best thing we can do is try and minimize all those risks, but even non-perfection can have a big impact on health. So again, risk factors, not disease guarantees. But if you do have an elevated lipoprotein A level, certainly this is something that for sure should be tested in people with a family history of heart issues. Is that running through your family? And if your test is abnormal, that should be a signal that first degree relatives, including children, should be tested for this. Again, it's not an emergency. This isn't something you have to rush out and tell, and tell your relatives have to go in for the test today. But when they have lab work, have them be tested for this, because it changes how we think about LDL, how we follow risk factors, and how aggressively we try and do prevention strategies. There are medications. Currently, there are no drugs that meaningfully impact lipoprotein A. There are medications in the development pipeline that are showing quite a bit of promise, showing LDL reduction with their use. It's going to be a while before they are available for prescribing, for a couple of reasons. Number one, there's still data that needs to be collected about long-term safety and efficacy. And then number two is, does it make a difference, right? If we lower lipoprotein A, does it truly impact risk or improve risk reduction on top of all the things we're already doing, like reducing LDL? If your lipoprotein A is high, because we can't get rid of it currently, right? Our workaround is to drop your LDL even lower, aim lower as your goal LDL. So if your goal LDL would be 130 based upon other, analysis of other risk factors, but you have an elevated lipoprotein A, we probably say, oh, you should be under 100. If your goal is to be around 100, but you have lipoprotein A, we might be aiming closer to 70, right? So.
Right. Great. We'll skip to this slide since we covered some of those other questions. We've had a couple questions come in through the chat as well about how to best use step one and what our daily recommended program is. So one of the previous questions was somebody who tried with 1 serving a day and is asking if we think their LDL could improve better with 2 servings per day. So if you want to answer that and just expand a little bit upon, is 3 servings better, or why we recommend our 2 servings per day?
Yeah. So the 2 servings a day is what we tested in the clinical trial. And the 2 servings a day aren't random. There's, the reason why 2 servings are important is because with those 2 servings, number one, we really help you. For most people that are most people in the U.S. are fiber deficient. They are behind by about 10 grams of fiber minimum per day. So 2 servings fills that gap. For plant sterols, you need around 2 grams per day in divided doses. So again, 1 gram, with breakfast. I'm just, making this up in terms of when you use them, but 1 gram with breakfast, 1 gram as your afternoon snack. That's a good way to, expose your system to kind of an ongoing intervention. So 2 servings would be expected to be more effective than 1. 3 servings might be even more effective than 2 from a, plant sterol perspective. Again, there may be and everyone's kind of individual, but at some point you're going to level off in terms of how much more benefit you're going to get from increasing plant sterol intake. In studies that have looked at this, there's not much benefit beyond 4. So 3 might be better. You're going to get a lot more fiber. So, so that may be one of the limiting factors is digestion. But, if you look at our ancient ancestors, they consumed about 100 grams of fiber per day. So we're way behind where they are. So if 3 servings, is something that you can tolerate from a digestive perspective, it's perfectly fine. There's nothing wrong with it. At some point, like I said, though, from a cholesterol perspective, you're going to plateau out in terms of the benefit, but it's typically not at 1 serving. 2 servings should be more impactful than 1. And then there's a question I see here about the 7 grams of fiber versus 5. There's a little bit of variability in the fiber in our products, but honestly, in the clinical trial, not everyone ate pancakes. It was a mix of products, so it's the entire line is really helpful. So no, I wouldn't say that 7 grams versus 5 grams makes that much of a difference in terms of cholesterol lowering. But 5 versus 10, yes.
All right. Great. All right, so we'll jump in. We had quite a few questions on this topic. So before we get into some of the more specific questions, Dr. Klodas is going to give us kind of a higher level overview of coronary calcium and what to look for, what you need to know about it. So we'll have her give a overview of that and then get into any more specific questions that she doesn't initially cover.
Yeah. Okay. So when I saw all these questions on coronary calcium come in, I actually brought in my heart model to talk about this. So I use this test quite a bit in my practice because I find it so useful in helping to individualize prevention goals for that I have for my patients. Not everyone should have this. If you have known coronary disease, so if you've had a heart attack, stroke, bypass surgery, stent, this is not a test for you because you already have documented heart, atherosclerotic heart disease. This is really for finding preclinical atherosclerosis. So before it sort of rears its ugly head with symptoms or with conditions. So here's how this test works. It's very simple but quite clever. So the heart sits in the chest like this. It's much smaller. This heart is like about as big as me. But what's convenient is that heart arteries follow very scripted paths on the surface of the heart. And what we do with a coronary calcium scan, which is a CT evaluation, we take 40 to 50 slices through the heart like this. And because CT scanners now are so rapid in how they're able to take pictures, we're able to capture the heart in relative standstill, even though it's beating. So on every slice, we can identify where the heart arteries are. Okay, so normal heart arteries have the same CT density as the rest of the heart. The heart's supposed to look like a big gray blob in the middle of the chest on a CT scan. Okay. As atherosclerosis, the buildup of this plaque, takes hold, one of the things that happens, it's not the very first thing, but one of the things that happens is that plaque, that gunk, starts to calcify. Calcium is a hard substance, okay? That's why the process is called hardening of the arteries, right? That's why we refer to atherosclerosis as hardening of the arteries. Calcium also conveniently happens to have a very different CT density. Calcium looks white and bright on a CT image. If you've ever seen a CT scan through a body, maybe your own, where the bones are, it's white. So we start to see white flecks where the heart arteries are. We can circle those areas on a computer, feed that data to feed that data in, and the computer will analyze the image down to its smallest pixel of information, blah, spit out a number, and that's your coronary calcium score. 0 means there's no calcium. 0 is a wonderful score to have. There's few times in your life you want to be a 0, but this is one of them. 0 means that you're in a very favorable prognostic group, meaning your chance of dropping over dead, having a heart attack, requiring bypass surgery, needing a stent, even having a stroke, incredibly remote. We can never say 0. There's no perfect guarantees in medicine, and we don't lose our minds if you have a 0 score. If you start having chest pain, we don't, ignore that. But a 0 score is associated, like I said, with a very, very low risk of anything terrible happening. And that low risk guarantee, it's not just good for a couple of weeks or a couple of months. It's good for the next 3 to 5 years. So it's a pretty good runway of kind of knowing that you're in a really favorable group, okay? Why do we put people on cholesterol-lowering medications? Well, it's not to improve numbers, it's to reduce risk. And if your risk is negligible to begin with, how much lower can I make it by putting you on a bunch of drugs? So this is where I find the test to be very, very helpful. And that is, someone with an elevated cholesterol level, but really not a lot else, is this someone who would benefit from statin medications, right? If you're 0, we can hold off on drug-based therapies. Doesn't mean we ignore the cholesterol. Doesn't mean you get to start smoking, right? It's still, that guarantee's not forever, right? We may want to repeat the scan in 3 to 5 years. Make sure you're still, in the right group. But it does afford us the opportunity to delay starting medications, right? And medications are wonderful. I prescribe them all the time. I'm not a statin denier or anything like that. I do use them, but I try to balance, right, risk and benefit. Some people, are in their 40s with high cholesterol. They're looking at 50 years of a drug. Right? Is this the right time to start it? Could we delay it a little bit? Because there's also the thought about drug exposure, right? The duration and dose exposure to a medication, that matters too. Okay, 0, super easy, okay? What if you're not a 0? Well, then it kind of, there's different levels. So part of the significance is where are you compared to your peers? So hundreds of thousands of people have had this test done. So we know where your score should fall compared to your peers of similar age and gender. Okay, so women should have no calcium in their 40s. They should have no calcium in their 50s. They should even have, no calcium into their early 60s. So 0 all the way into your early to mid 60s is normal. For men, they're about 10 years behind. So 0 up until middle 50s to late 50s is the expected score. Okay, so you're not a 0. What if you're 100? Okay, well, that's enough calcium buildup and enough sort of atherosclerotic burden, right, extent of atherosclerosis for us to say, wow, well, not only should we be pretty aggressive in terms of, cholesterol management and, nutrition and exercise and all those things, you should also be on an aspirin a day. There's a fair amount of gunk in here, okay? 400 would be, I don't care how well you feel, you just bought yourself a stress test, okay? The highest score I've seen where I've ordered the test on a patient we were just checking, right? They didn't have any symptoms. They just had some risk factors, 2,217. And when I talk to my patients about this before they have the test, I said, okay, what if you're my new record holder? 2,218, okay? First thing I would say is do not freak out. I mean, 0 is way better, don't get me wrong. But if you have a high score, do not freak out. That calcium didn't just appear overnight. It has been building and building and building over many years. Remember that 0 score is good for 3 to 5 years, right? So over 3 to 5 years, you could build something, up, but it's building over that amount of time. Okay, so if you're 2,218 today, you were 2,218 yesterday, you're 2,200 a couple of months ago, you were 1,500 a year or 2 years ago, right? This stuff has been here. You've been living your life, you've been, going out to eat, you've been traveling, you've been working, whatever. This stuff has been here. So it's not that you're any fundamentally different. It's just that we have a new piece of data about you that allows us to be a lot more objective and personalized in terms of, of prevention efforts, right? It's merely a nodal point on a decision tree. And I get really perturbed when I hear someone say, like, I had a calcium score, it was high, and they took me for an angiogram. It's like, why? You had no symptoms. Like, that makes no sense. You had the same score even weeks ago. So this is just one piece of data. Doesn't mean we ignore it, doesn't mean we take it lightly if it's elevated, but it's not an emergency. Okay. And the other thing I want to say about the other thing I want to say about a coronary calcium scan is sometimes you will get numbers that are so precise, right? Like it'll be 34.3, okay, to a decimal point. The test is not that precise. Really, we should think of it as calcium, yes, no, a little or a lot, and where do you fall compared to your peers, right? So if you're a 45-year-old woman, calcium, yes, no, you should be a no. But if you're a yes, then it's okay, well, that's abnormal. A little or a lot, even a score of 1, okay, that's a little, we'd still be worried about it because where are you compared to your peers? You're ahead, right? We'd start to think about being far more aggressive in terms of prevention efforts and really think about starting you on medications for cholesterol to reduce risk. Do statins help stabilize calcium buildup? Okay, so calcium's not the problem. Calcium is the marker of the problem. Calcium in many ways is the objective visualization of our body's cell, repair mechanism at work. So as this gunk is depositing in our arteries, it's not depositing linearly and smoothly. It's depositing in lumps and bumps. That's why someone can have a 90% blockage and we put in a stent that's literally this long and we open it up, right? So it's not that the whole artery was 90% blocked. It's just that one little spot was blocked. So this stuff really deposits more like pimples on the inside of our heart arteries. Well, if you have a pimple on the back of your hand, and if I were to take sandpaper and drag it across the back of your hand, where's the skin most likely going to break down? It's where the pimple is, right? This area is weakened, right? There's stuff in there that doesn't belong. The skin is stretched. The underlying architecture of the skin has been disturbed by, white cells and inflammatory cells. It's inflamed, right? It's an area of vulnerability. Okay? Same thing with plaque. If you have a plaque pimple, that's an area of vulnerability. And that, there's stuff in there that doesn't belong. Cholesterol, fat cells, inflammatory cells. The inside lining of the artery is stretched. This is a vulnerable spot. And you can think of risk factors not only helping build this stuff, but acting like little pieces of sandpaper floating around in the bloodstream. The more risk factors you have, the more likely sandpaper and plaque will meet, and that can lead to, these out of the blue events like heart attacks and strokes. Okay, our bodies are designed to survive and thrive. We are always on the lookout for threats, both external and internal. This is an internal threat, right? The body says, like, wait a second, I've got this plaque pimple. This thing is a vulnerability for me. It could break down. It could cause a heart attack and stroke. That's not good. What am I going to do? I know. I'll reinforce this sucker. I'll put up scaffolding. I'll make sure this thing is solid so it can't break down. That's the calcium. If you look at plaque under an electron microscope, you will see cells that for all the world look like bone cells busily laying down calcium. That calcium is permanent. Once the scaffolding goes up, it stays up. But to some extent, like, who cares, right? If you're going to have plaque, you want plaque that's stable, that's protected from breaking down. So it's not that the calcified plaque is the problem. It's that we know that wherever we see calcified plaque, there's uncalcified plaque. And the more calcified stuff there is, the more uncalcified stuff is likely. And it's really that we are trying to intervene upon when, and regress and undo when we are being aggressive in terms of prevention efforts. So it's paradoxically the stuff we can't see that we're trying to fix. So do statins help stabilize calcium buildup? They may have no impact on it at all because the body is doing that. What I would say that statins do is because they and all cholesterol lowering methods, they reduce the impetus to build more plaque, which means you're giving your body a break. Like, rather than it, spending its energy on building more plaque, it can devote more time and effort to stabilizing what's there, which is another caveat around coronary calcium scans. If you have calcium, you should never have the test repeated again because it's never going to be better, right? The calcium never goes away. That's number one. But number two, if the score is higher, I don't know what that means, right? Did we do everything right? And now your body is showing us that it's repaired more of the plaque that was there, meaning the amount of plaque hasn't changed. It's just more of it is stable now. Did you accumulate more? I can't tell that from a calcium scan, and it doesn't matter because it won't change what we're doing. Once we detect calcium, especially far more calcium than what would be expected for, based upon age and gender, we're going to throw the kitchen sink at this and be really, really aggressive in terms of prevention efforts.